Okay. Well, it is just past 10 o'clock, and I want to welcome everybody to the Delta Center for a Thriving Safety Net Payment Reform and Value Improvement at Mosaic Medical webinar. At the Delta Center for a Thriving Safety Net, which is an RWJF-sponsored initiative that's dedicated to advancing value-based care and payment for primary care and behavioral health through both practice and policy. We are frequently asked for real-world examples of value-based payment and care and how it is being implemented. And we are delighted to have two panelists with us today to share their story. I'm going to pause very briefly to give a couple of Zoom tips for those of you who are online. One is that all attendees are automatically muted upon entry, and this is just to minimize the background noise. However, if you do have questions or technical issues, please use the chat box to both ask questions throughout the presentation. We will be collecting them and then passing them on to Megan and Marshall at the end to answer. And if you have specific technical requests, please direct message Tracy Karui, who is poised to try to help with any technical issues. Finally, this webinar is being recorded, and the slides and the recording will be posted on our Delta Center website in the next couple of days for broader dissemination. So with no further ado, I would like to welcome and introduce Megan Haase and Marshall Greene, both hailing from Central Oregon from the Mosaic Medical System. Megan was one of the first two nurse practitioners to serve at Mosaic Medical when it was a clinic serving just over 600 patients. And it has clearly grown, now serving more than 23,000 patients, and Megan assumed the CEO position starting in 2010. We are also delighted to have Marshall Greene, who is the Director of Value Improvement at Mosaic Medical. And in his role, he leads the quality improvement, population health, and data and analytics teams, and brings approximately 6 years of experience serving at Mosaic Medical. I am now going to turn it over to them to share with you their story of both changes in value-based payment and care in Central Oregon. Megan and Marshall, take it away.
Great, thank you.
Thank you.
We're really excited to be here today and share some of our journey and our learnings along the way, and we really look forward to the end of the webinar where we get to dialogue with the group and answer questions, and we feel like we get an opportunity to learn as well. So the agenda for today is starts with a little background about Mosaic to give the group some context about our journey, and then we're going to dive right into the value-based pay evolution for Mosaic. Since about 2010, we've been on this journey. Then we're going to go into more detail about our value-based arrangement with our Medicaid line of business. And then we're going to spend some time sharing the impact of this journey, some of the challenges, and some of the mulligans with the group, and then we'll have time for questions. So Mosaic Medical is a regional community health system across Central Oregon. We serve 3 counties. We've grown pretty significantly. We started in 2002, and like was said, we served about 600 patients in 2002, and now are close to 23,000 in the last 12 months and close to 27,000 in the last 18 months. Central Oregon has about 230,000 lives living in our region, so we're serving about 1 in 10 or more of the population here. We have currently 11 satellite sites that are supported by 5 main clinic sites, and in addition, we do have 2 administrative locations as well. And then you can see on the screen, in addition to our patients served, we've done close to 90,000 patient visits. Some context for the population we serve is we have about 55% of our patients have Medicaid as their health insurance. We have about 20% of our patients with Medicare. We have an aging population in Central Oregon, and that particular line of business is growing. We have about 15% commercial, and then 10% are uninsured. What has been interesting, Oregon did expand Medicaid through the ACA in 2014, and we went from 33% uninsured in 2013 to now only 10%. So there's been a really big impact in our community and with our patients on obtaining Medicaid coverage, which was just really significant in the care of our patients and their lives. So some context about what services are offered at Mosaic, which is similar to many of the community health centers. We have a complement of primary care services, including family practice, pediatrics, internal medicine. We have a complex care program targeting our most vulnerable patients from a medical, behavioral, and social complexity perspective. And then at some of our locations, we offer prenatal, and in one of our locations, we also do deliveries. We have grown substantially our behavioral health services. We have a behavioral health consultant embedded in every one of our primary care teams. We also have grown a substance abuse support program. We call it Transitions, and our first area of focus has been on opioid use disorder and medication-assisted therapy. Our next area of focus will be on alcohol use disorder. We also have a chronic pain management program, and then we also have our psych NPs prescribing psychiatric medications, and we also have a telepsych program in one of our rural clinics. We also have added registered dietitians and working with our patients around nutrition, both in individual settings and also in groups. We've added 4 clinical pharmacists to our team, and then we've most recently gone into the dental and oral health space with having 2 dental clinics as well as dental hygienists embedded in each of our care teams. So that's just kind of an overview of what our services that we are able to offer here at Mosaic. And then this slide is really just kind of high level, an overview of some of the themes and lessons that we've had as we've been on this value-based population health journey. One of the themes is it's really critical to have comprehensive primary care services with some of these ancillary provider roles to help serve the population. Our data and analytic team, we've invested heavily in that over the years to really grow both our FTEs, but also what our talented analysts can do and provide as far as data and information to drive care and evaluate the effectiveness of programs. We also have, what you heard earlier, Marshall's role has 3 of our critical components: quality, population health, and data, actually under one leader, because the interrelation between them are really critical as we drive to the future from a value-based perspective. And then another lesson that is we have learned over the years, it's really critical to have leadership buy-in, and that buy-in needs to come with a deep understanding of the why, and it's both important on the operational side as well as the clinical side. And then the other theme for us has been a very strong relationship both with our state as a payer as well as our managed care organization locally. Our relationship with them is very strong. And we'll go into more detail about some of those learnings in a bit. We also thought it might be helpful to share some of the early influences or contexts back in 2010, 11, 12 that I think created space for us to be on this journey. Central Oregon is a unique area in that we are geographically isolated, and we have one health system, one major managed care organization payer, one large community health center with a partnership with another community health center. So we have a lot of ones for the key entities in designing a community's look to value for a population. And again, like we talked about, we have a very, very strong relationship with our local Medicaid managed care organization. There is a high or a deep understanding in our region on the importance of primary care in value-based pay and population health management. Our region also was an early integrator of behavioral health with some demonstration pilot funding from the state even back to 2010. And then there's a recognition that it's really important to be data savvy to be successful in a pay-for-value world. And now I'm going to turn it over to Marshall, and we're going to dive into the value-based pay evolution.
Yeah, so Megan provided some of the early context or background just now, and I'm going to sort of dive into how Mosaic has evolved to incorporate value-based pay, and in doing so, we sort of broke this into three separate buckets into the ways in which we have evolved, and those are evolutions in our care team, evolutions in the payment structure, and then finally evolutions in the IT and data systems, as well as how we think about quality improvement. So diving into the care team a little bit, you can see our chronology here. As Megan mentioned, we were early to integrate some of these roles. We had a community health worker role even before any real value-based contracts in 2003. And then starting in 2010 was when we really became more proactive and started working closely with our Medicaid managed care organization. And we developed the nurse care coordinator role, and at that time they had some assigned panel management duties. Likewise, as Megan mentioned, we integrated behavioral health early on. In 2011, we had some physical changes in the way that the teams were set up so that the teams were co-located with both the MA and provider teamlet as well as the integrated services. And we had a new role, the team care assistant, and so we had this sort of triad of the nurse care coordinators, the team care assistants who were doing additional outreach, and then the CHWs who were helping to coordinate addressing social determinants of health issues, as well as at that time, a lot of transportation issues. In 2013, we launched the ambulatory ICU, as we sometimes refer to it as, which was the complex care program that Megan mentioned. That is a referral-based program that serves to address the needs of really the top 5% of highest risk patients. And that program serves not only Mosaic patients, but we actually receive referrals from other regional organizations who have patients that are identified as meeting the criteria to participate in that program. And so they come see us sort of as an interim PCP, and we'll try to get their care managed, and then we sort of refer them back to their original PCP as appropriate. In 2014, we started to focus on some pathway developments for chronic diseases. We started with diabetes, and likewise had followed up with hypertension. And at the time was when we started to invest in motivational interviewing and some health coaching work across several roles in the organization. In 2016, we launched the substance abuse disorder program that Megan mentioned, focusing on opioid use disorder and integrated MAT. And then more recently, this year, we've really looked at and reevaluated how our nursing structure works, and we created a new role, which is the nurse care managers. And those nurses are targeting sort of the group of patients that are one step down in terms of acuity from our complex care high-risk patients. So it's really the sort of 5 to 15% of the high-risk patients, usually having multiple chronic conditions. We focused on diabetes to begin, but in that role there, we have launched a chronic care management program where we're billing Medicare for that. So that's the care team. In parallel, we had an evolution in our payment methodologies. Our first pay-for-performance program was in 2010, and we started receiving a capitated model in 2012. That's evolved over time, but in 2012 there was a sort of a supplemental per member per month payment tied to participation in a program called PCPCH, or Patient-Centered Primary Care Home, which is Oregon's version of the PCMH that many of you may be familiar with. In 2013, the launch of Oregon's Advanced Payment and Care Methodology program happened, and Mosaic was one of, I believe, three pilot sites. Megan is motioning to me that it was only 3. One of 3 organizations in the state to participate that in the first year, and that has grown substantially. I think there's now 18 participants, which is more than half of the community health center organizations within the state are now participating in that. And because we knew in 2013 that Medicaid would be expanding, we really started to try and plan for the expansion of our Medicaid population, knowing that our patient population was likely to grow. And so we did some additional work in formalizing the empanelment process for patients, and thinking about panel sizes and doing some projections on how many patients a given provider could take on. In 2014, we, of course, did have the Medicaid expansion in Oregon, and overnight that increased Mosaic's Medicaid population dramatically. For Mosaic, I think we went from something around the lines of 7,000 patients to 12,000 patients that were Medicaid insured. Likewise, that was the beginning of a gain-shared contract with our hospital system, and I'll talk about that in further detail. And then in 2016, we developed a quality incentive contract with our local IPA. That's ongoing. And finally, in 2017, for our Medicare patients, we joined an accountable care organization, or ACO, in which we're still participating. In thinking about our data and quality improvement evolution over time, we implemented EPIC in 2011 as part of the OCHIN organization. OCHIN, if you're not familiar with them, are an organization that hosts EPIC primarily for community health centers. I believe that they have over 100 community health organizations across the country, but they actually began in Oregon, so that partnership was relatively easy for us. In 2011 was our first hire around quality and analytics. It fairly quickly became apparent that we were going to need additional analytics support. So in 2012, Mosaic hired its first data analyst. And at that time, we worked on a model for quality improvement, adopting quality huddle boards, and formalized quality huddles, and introduced the PDSA quality improvement process. In 2013, we recognized that in addition to the analytics FTE, that we were going to need to invest in additional data infrastructure, so we adopted our first business intelligence tool, Tableau, and began doing some internal data warehousing to support our data work. And at that time, we hired our second data analyst, which was actually me. In 2013, we also introduced the population health specialist role, which is really focused on doing panel management around gaps in care and doing bulk outreach as appropriate. And that role has continued to grow and evolve. In 2014, we began working with our local coordinated care organization to receive data files for our Medicaid patients. These provide additional cost of care data that we would not otherwise have access to, as well as providing us with data on emergency department and inpatient utilization. So that was sort of our intro into that level of care coordination and trying to think about how we could start to work to bend the cost curve for our patients. In 2015, further investments in our data team included a third FTE, as well as investing in some data prep software and formalizing a population health model where we're stratifying patients based on patient risk. In 2016, we rolled all of our quality improvement and population health and data team into one department called the Value Improvement Department, and hired another population health specialist while having a population health manager. In 2017, we then introduced the quality medical director role. So this is a role that works closely with our population health and quality improvement team to provide their clinical knowledge and clinical decision making in helping us to prioritize the quality improvement work that we do. So that was our evolution over time, and now I want to turn to some of our current Medicaid payment streams and sort of talk about how they are currently set up. The biggest program that I mentioned was the Alternative Payment and Care Model program that began in 2013. This was developed in close partnership between the state as well as the state's primary care association, Oregon Primary Care Association. And this was an alternative to the standard PPS payment system, and this was actually the first program to be launched nationally as an APM program as an alternative to the PPS program. In this program, we continue to have capitated payments, and there's quality metrics which have an associated downside risk if we don't meet certain benchmarks. And it's worth noting that for this program, the capitation only covers our primary care medical costs, and there's carve-outs for all of our prenatal, mental health and behavioral health, as well as dental. As the largest of our value-based pay systems, I thought I'd dig into the goals of that program. And they describe it as the goal to align up payment with an efficient, effective, emerging care model that lowers overall costs while improving quality, access, and health equity for all. And they've developed these 4 quadrants that align fairly closely with the triple or quadruple aim. And one thing that is unique about this program is that it really allowed Mosaic and the other participants to focus on patients and health outcomes over billable visits. So this encourages us to create robust care teams as well as adopt new ways to connect with our patients, be that over a patient portal or doing telephone visits, and then also to begin to address the social determinants of health. And while that may not seem particularly novel in 2019, in 2013 that was still considered pretty cutting edge. So the role of APCM for Mosaic has been that it provides a predictable and timely funding structure. And again, that's allowed us to really round out our clinical roles and services. It also provided us an external validation of how we were thinking about our vision and direction, because those were often aligned. OPCA has provided a lot of leadership across the state and has helped the dialogue with the state and provided vision in that regard. I mentioned strong support with the state. That partnership between OPCA and the state has been strong and continues to be strong. And it's provided partnerships with other community health centers in the state, allowing us to do peer learning, a lot of quality improvement, best practice sharing, as well as actual data sharing in terms of how each of our organizations are doing over time, and identifying best practices, and providing an opportunity for us to recognize when there's opportunity for improvement. Our second major Medicaid payment stream is a capitated payment through our regional coordinated care organization. This started a little earlier in 2012. The Medicaid care organization, or coordinated care organization, assigns patients to Mosaic, and because our payment is so dependent on the number of assigned lives, when this program began, Mosaic felt the need to hire additional enrollment assisters because maintaining patients' Medicaid coverage was vital to maintaining this payment stream. And again, this program has carve-outs for prenatal, mental health, and oral health. The third major payment stream is a shared savings contract with the hospital. Interestingly, within Central Oregon, as Megan mentioned, we have sort of a lot of ones, which is to say we have one major hospital system in the region, and the hospital's services are also capitated, which is a little unique, and the local hospital has a financial withhold that is tied to both quality and utilization targets. And when benchmarks are met for those, the incentive goes to both the hospital as well as local providers. What we found is that this provides a great way to align our work. So it means that we have good partnerships in terms of trying to reduce ED and inpatient utilization, that all the players are really willing to work together to move the dial on some of the quality and utilization metrics. A couple of additional Medicaid payment streams that we have. we have a quality bonus with our local IPA. This is a mixture of sort of the standard clinical quality metrics that we're all familiar with, as well as some process measures that our IPA has identified as a priority. One example of that is providing bonuses for offering additional extended hours in the region, things like that. Another example is encouraging providers to get their MAT waivers, and this is funded through a small PMPM that's taken by the IPA prior to it going out to the individual organizations. Finally, if at the end of the year there's a surplus in the Medicaid Coordinated Care Organization's budget, then there's a shared bonus that's paid out to the hospital, the specialists in the region, as well as the primary care organizations. So what has been some of the impacts of having Mosaic work to increase our value-based pay contracts? As I've highlighted, it's really encouraged us to integrate robust clinical care teams. We now have dental, behavioral health, substance abuse, clinical pharmacy, clinical nutritionists, as well as care managers. And as I mentioned with the APCM project, it's allowed us to meet our patients' needs outside of the traditional face-to-face PCP visits. At least 2 of our clinics, we're now doing routine phone visits, primarily as follow-up to a face-to-face visit. We have clinician-led group visits. Some of these are at the provider level for diabetes education, hypertension education, but then also by clinical support staff. So CHWs are leading some classes. We do patient education classes. We're continually trying to expand our use of the patient portal, which is to say our online secure email. And we recently adopted a telepsych program for one of our rural sites, and planning to expand that in the near future. And as I mentioned, it's really forced us to improve the culture regarding the use of data and analytics, as well as quality improvement within Mosaic, and in partnership with our payers in the community. One example of how we've really had to focus on quality improvement was in 2018. We had a big focus on improving our hypertension blood pressure control measure. This is a measure in which you're probably familiar with, but if not, for all of your diagnosed hypertensive patients, what percent of them have their blood pressure controlled to the 140/80 level. And we recognized actually even in 2017 that we were, that there was a big opportunity for improvement for Mosaic, and that we weren't meeting all of the quality benchmarks that we were expecting to. And so we had really an all hands on deck across the whole organization quality improvement project. And you can see, we went from low 60s or right around 60% completion on that up to over 70% through what really ended up being more than a year's work and focus on this quality incentive measure. And we're now, well within where we want to be for that measure. And in 2019, we've adopted a similar project for diabetes care management. this includes, of course, the A1C control measures that is standard, as well as adopting the Minnesota D5 composite, which is a all or nothing measure that has 5 components for optimal diabetes control or management, and we've put a lot of work into that over the course of this year. So what are some of the challenges that we've experienced with our transition to value-based pay? One is that there are disparate requirements across payers. And so we have different quality measures, different access measures of focus across different lines of business, and then within the different Medicare payers as well as commercial payers, they often are focused on different measures. So trying to come up with an aligned strategy can be challenging. I think the culture shift internally from fee-for-service to value has been a challenge. We may have had a misstep a couple of years back when we had a bit of a focus on productivity with our PCPs, and that has been hard to shift the mindset away from in the last couple of years as we increasingly move to value-based pay, where productivity is not necessarily the highest priority, where these quality scores increasingly matter, where patient experience increasingly matters. One thing that we found is that for some of what we're doing, we don't really know how to measure success. So as an example of this, in our alternative payment methodology program, the APCM program, we've been really working to focus on how we can deliver care outside of the traditional face-to-face visit, but we don't really know exactly what the right ratio of PCP visits compared to clinical support staff visits compared to phone visits. We don't really know what the best practices are because we're sort of in this new environment and there aren't established best practices out there. For our finance team, the value-based pay world does create a fair amount of uncertainty in our funding streams. When we have money that is tied up in quality improvement measures that we may or may not get bonuses for at the end of the year, that can be a challenge. And as we expect increasingly there to be downside as well as upside risk, that's going to continue to be the case. And I think the culture of sharing the care, which is to say that all of our clinical support staff are aware of their roles, and that the PCPs are really working with the clinical support staff, because that's a shift for them as well. And if we could do it over, what would our mulligans be? One big one would be ensuring that the operational and clinical leadership have buy-in before we adopt some of these programs. This actually sort of goes back to the case of the productivity versus value and quality improvement. We've had some programs and initiatives where we sort of jumped in feet first without necessarily getting full leadership buy-in and explaining the why well. And then the practice improvement staff, so those roles, usually part of the population health and quality improvement team, that are really working with clinical staff. They need to be highly relational and facilitative in their manner. It's easy to create a bit of tension between this quality improvement staff and the actual clinical staff. And one learning that we had was our value improvement team, which again encompasses the population health team as well as quality improvement and data and analytics, had been reporting through our operations team, and we found that reporting through our clinical team provides a closer relationship with the clinics and clinic staff, and has been a better fit overall. Some of our future work relates to continuing to shift the mindset to sharing the care and increasingly using team-based performance metrics, so quality measures that are not directly tied necessarily to just medical staff, but also some of our clinical support staff. Continuing to develop our risk stratification model and the pathways that we use to manage chronic diseases. One ongoing shift in culture is having the care teams think about their population beyond the patient who is there for a visit today. Alignment across payment models and the different metrics that we're being measured by. We're continuing to work on that, and part of that includes improved contracting with the state and with different payers. Of course, employee, provider, staff well-being is always important. And in the near future, we expect to continue to increase the number of our value-based contracts, and going forward, it'll probably be more on the Medicare payer side of things instead of the Medicaid. So with that, we are open to answer some questions, and I see some have come through in the chat here. I'll read those, and then we can discuss those, and feel free to continue to add more questions. So Robert asks, hospitals are capitated based on number of Medicaid lives or paid a case rate, formerly the DRG?
They are capitated based on the Medicaid lives for the hospital services.
Next question is by Megan. Can you say a bit more to clarify the difference between payment streams 1 and 2? Yeah, absolutely. So the payment methodology is similar in that they're both capitated, but the programs are orchestrated at different levels. So the APCM program is through the state and is actually through the state's primary care association. Well, the CCO PMPM is a regional payment, regional to Central Oregon, and they both are tied to quality measures, although the quality measures differ a little bit. Is there anything?
Well, I think maybe in some states the way the RAP works, it might be different. So in Oregon, the RAP payment comes directly from the state to community health centers, and so the APCM payment is a direct relationship with the state for that part of our Medicaid revenue. And then our additional revenue comes through the managed care organization, and we're paid directly from the managed care organization a capitated rate for our primary care patients, and that rate is similar both with community health centers as well as non-community health centers. And then that RAP payment that comes from the state makes up the difference for the cost-based reimbursement that community health centers receive for Medicaid lives. Hopefully that helps.
Another question asking about getting a copy of the presentation. Yes, I think that we can arrange that. I assume that that was planned. Yes, definitely. just waiting for any more questions to come in through the chat box. Can you talk about the shift in staffing brought about by your participation in payment reform? Yeah, I think that the robustness of our clinical services is really has been tied to the payment reform. So the integration of clinical nutrition, clinical pharmacy, behavioral health, those have all been fairly intentional additions to our care teams, as well as the nursing care managers, to help sort of ensure that we have the proper services for patients of differing risk and care needs.
And one thing that's helpful when you move away from mostly fee-for-service that's directly linked to that PCP visit to a payment that's capitated or linked to the patient, it does allow you to look at different clinical roles to round out the expertise that we can offer to our patients in a more flexible way. So that's been a huge value add, and we've been able to we have patient advisory councils, and we currently are going around and meeting with them to talk about our next strategic plan, and they have really appreciated having non-PCP clinical interventions for different conditions, like diabetes is a great example, and some of our patients spend quite a bit of time with our clinical pharmacists who are very adept at the complexity of medication management today with diabetes, or they spend time with our nutritionists, and the nutritionists do have more time than a traditional PCP visit, so they can do a lot of education so the patients really start to digest the impact of what they eat on their disease more than they had been able to in the past. So that's been one of the great shifts away from fee-for-service to these capitated type of payments or quality-based payments, that we're able to offer additional clinical resources that are huge value adds to our patients.
Next question here was, do you use a risk stratification tool, and if so, can you share it? Can you also share team dashboards examples? We have a couple of different ways in which we stratify patients, and for our Medicaid patients, we are provided from our Medicaid managed care organization the VERISC risk stratification, which is a risk scoring system that predicts total cost of care, future total cost of care. We use that for some of our programs. We also have an internally developed risk model that is based on number of chronic diseases, both physical and mental health, and then also demographic data. We use that primarily as a way to level set our panel sizes, but we've also used it to identify patients who are appropriate for higher need care services. When you say, Jeff, share a team dashboard example, I'm curious if you mean in terms of the quality metrics, or which we'd be happy to do. We certainly have examples of that. Or if you're thinking in a different sphere, and you can just chat that in, and we'll follow up with you on that. Can you speak more about participation in Medicare ACO and your plans for Medicare? Does this include PACE?
Sure. So we are currently part of Caravan Health ACO, which started out as a regional ACO here in Central Oregon, but because of some of the changes with the ACO, they wanted to expand it and make it a much larger ACO. So now our ACO covers many more. Do you know what the number of lives now?
I don't off the top of my head, but
100,000.
yeah, it's over 100,000.
And
yes.
It's across the state with different organizations, large and small. Interestingly, we're going into our third year in 2020, but for 2019, it's looking like we are going to actually have some shared savings. So it has been successful so far for us. We've certainly had some challenges, and that could be a whole other webinar with the ACO. Our current plans for Medicare in our community is to work with our local payer here, who is also the payer for Medicaid, to create a value-based Medicare product that mirrors more what we have in our value-based Medicaid contract. There's some work to do over the next couple of years with how we do our HCC coding more accurately to make sure that we're capturing the complexity of the lives, so the dollars that come into our Medicare Advantage plan are the right amount of dollars, which will create more flexibility in what we can do for value. And we think there's a lot more, we are more interested in a Medicare Advantage value-based arrangement versus the ACO, because there's much more flexibility when you work with a Medicare Advantage plan. And there's a lot of opportunity in Central Oregon for Medicare lives to go into an Advantage plan. We have a low penetration of Medicare Advantage. It does not include PACE. We are not really well versed in PACE in Oregon, but I know there's a kind of a state program around PACE, and it is something that we're going to need to learn more about as we increase our focus on the Medicare population. That's part of our strategy over the next year, and will likely be in our next strategic plan as well. So we're not probably as versed as you are in our region around the PACE program, but we would love to learn.
Next one is, how have the changes in payment staffing changed outcomes for complex patients? That is a great question, and it's one that on the quality side is fairly easy to measure in terms of the standard quality metrics. We see especially with the highest risk patients who are part of the complex care program, that we actually have better quality scores with those patients because they're getting such consistent access to services, and they're getting such a high level of support staff follow-up. With regards to total cost of care, we've been measuring that since 2016, and it does appear that total costs do go down. There's a lot of noise in that data, as you can imagine. There's wide ranges in the sort of claims costs, or shadow claims as it usually is, because we have so many capitated contracts regionally. It's difficult to measure, but it does seem like we are saving money for those patients who are enrolled in the complex care program. I'll do that one.
Okay. So the next question is, Marshall, since moving to the APCM, have you seen traditional face-to-face visits per member go down, or have all the alternative care, the CHW visits, the phone visits, et cetera, been additive as opposed to substituting for some of the traditional face-to-face primary care with billable providers? So I would say our face-to-face visits have gone down. Our thinking about face-to-face visit care is that it needs to be the type of care that needs to happen in the clinic, and we want that care to be comprehensive. We want to address the needs of the patient. We don't want to have them pick a couple things and they have to come back a week or 2 weeks or a month later, because there's so much work to do a visit outside of the visit actually occurring. So the more you can sort of consolidate what you do in a visit is much more efficient actually for the PCP and the patient. And then we're finding that there is a lot of care that can happen outside of a visit much more conveniently and effectively for patients that are interested in that. Also knowing that you really want to offer a menu of services to your patients so they can choose what best meets their need. And there certainly are some patients that that from a social perspective, there's a lot of value to having that face-to-face visit for things that maybe you could have done over a phone. So we like to keep that flexibility. But our face-to-face visits have gone down. They've been pretty static for the last few years, and we've been growing these other types of touches with patients over time. And some of the growth comes from being better at documenting and capturing these other types of care, and some of it comes from actually increasing these other types of care interventions.
All right. I think we're getting the signal that that was the last question for now. We can follow up over email for any additional questions that come in.
Oops, there's one last question.
Oh, okay. What factors influence PCPs to make the culture shift from fee-for-service mindset to one based upon population health?
Well, I don't think we're totally there yet, so we're still working on that shift, and a lot of it comes from our dialogue together with the PCPs and PCP leaders when they're thinking about, ways to improve. There's a couple of them I can think right now that think about, if we can do more visits, then we can pay for this other intervention. It's like, no, if we need to not think that way. If we increase our panel size, it could bring in more revenue to expand what we can offer within Mosaic for the patients. So it's a constant dialogue and conversation, recentering on the why, and taking any opportunity to really reinforce we need to be thinking differently about how we're approaching care. I think one of the things that has really helped most recently is creating formal phone visits within the template of the schedule of the PCPs. So they're actually doing a different type of alternative care touch that lives documented on their schedule for the day. And as we think to the future, that template of the day that's gonna be where we're gonna see the different care interventions, and I think that will help the teams really digest, so the way we're organizing our day is not just these face-to-face visits and we try and fit things in outside of that. We're actually building our template very intentionally with all these different care modalities. And then our teams will also have templates of the day for doing interventions like the clinical pharmacist and the nurse care manager and those other types of roles.
And I think with regard to the phone visits, that I think the providers are pretty aware that those are not billable. So I think that helps the sort of mindset shift where, okay, it's not just about how many patients I get who I see through the day. It's really about this shift in providing care as it's needed and desired by the patient, as well as providing the quality of care that we're hoping for.
Well, Marshall and Megan, I am going to try to wrap us up because we're about 2 minutes before the hour. I want to thank you both for all of your insights and for everybody who participated online. For those of you who have remaining questions, feel free to either contact Megan or Marshall directly or to contact us at the Delta Center, and we are happy to make sure that the questions are forwarded and that we get them back to you. The other thing is that these slides will be posted online at the Delta Center website, as well as the full recording of this webinar if you are interested. Finally, there's further opportunity to be in touch with other offerings like this by signing up for the Delta Center website. For the Delta Center newsletter, which you can do on the Delta Center website. And then finally, another resource for you on the Delta Center website is a case study that JSI did on the Mosaic Medical experience if you prefer to read rather than listen. Once again, thank you so much for sharing your real-world experience, and thank you to all of the participants for attending today.
Thank you.
Thank you.